So
Hello and welcome to everybody. I am so delighted today to have this session on World Health Day, 7th April. The good health is what we are going to talk about it on Good Friday for the goodness of mankind. 7th April, we mark the World Health Day around the globe, and I am very delighted that we have one of the very, very blessed team here. Absolutely the tycoons in their own field, Dr. Shrikant, Dr. Anand, Dr. Sharmila, and Dr. Shruti, who will be talking about and only the Coles lady, Dr. Ashima Sharma Agrawal.
so your voice is
It's
cracking.
going to be a great fun and great timing. I return only so that we have enough time to Dr. Garima to move on further with the introduction of Dr. Anand. And again, a sincere request for everybody to stick to the time frame of 5 minutes of presentation. Thank you. Take care. God bless and enjoy the academic feast. Bye-bye.
Thank you, sir. Thank you so much. I welcome you all on behalf of Hyderabad Elite Doctors. Our first speaker today is Dr. Anand. He's an MBBS, MS Orthopedics from SRM University, Chennai, Fellowship in Pediatric Orthopedics and Cerebral Palsy from Institute of Pediatric Orthopedics, Mumbai and Manchester, UK, founder and director of Institute of Pediatric Orthopedics and Gait Disorders, Hyderabad, consultant pediatric orthopedician at Apollo, and other group of hospitals. We are very pleased to have you, sir, here, and you are a very good photographer. We have seen a lot of pictures clicked by you, and you're very good with kids. So the platform is all yours, sir.
Thank you, ma'am. Thank you for the very good introduction. I'm a very simple person, actually. You have told a lot about me. However, today, actually, we thought of talking about myths that circulate around in common population, and it becomes very confusing over a period of time to, we really don't understand what's happening around. So it's like that.
Anand, you are not audible.
Anand, sir, you got muted. Dr. Anand, you're on mute. Now you're audible.
Yeah, yes. Can you hear me now?
Yes, we can hear you now.
Yes, ma'am. Sorry. So, shall I start my presentation now? Ma'am, shall I start my presentation?
Please go ahead, sir.
Yes, ma'am. So, good afternoon, everyone. Today we are going to talk about some myths and facts about healthy bones. So, I'm Dr. A.V. Anand, consultant pediatric orthopedician, IPHGD and Apollo Group. So,
I think we can't see your presentation very clearly. It is half of the screen.
Can you see now, ma'am?
It's half. Is it for me or it's for others also?
We could see the full screen. We could see the full screen.
We can see it.
Okay,
yeah, we can see it.
Shall I start my presentation, sir?
Yes, sir. Please. Sorry to interrupt.
Yeah, no problem, ma'am. Yeah. So this is a very funny video the other day I got, where this guy is kind of doing a pranic healing, it seems. So I really felt we should start our talk today about myths with this kind of video, where there's a very, very bad troll going on around him. Hello. So the patient here clearly asked, like, if you do a treatment from there, something like pranic healing, how does it really going to change things here? So this kind of myths you should stay away from. So first thing I'm going to talk about is the sunlight and strong bones. Time and again we are being told by our elders and many doctors also sometimes that early morning sunlight is very important. That's absolutely wrong. See, vitamin D actually is produced, especially when you get exposed to sunlight through UVB radiations. Those are available only from 10 a.m. to 2 p.m. So please tell your babies or anyone older person also to sit in the sunlight at 10 a.m. to 2 p.m. only, which is really going to be helpful for them. That's it. And not early morning sunlight. Actually, early morning sunlight is more carcinogenic and more bad. Actually, it has UVA radiations. So that should be avoided. And next, deficiency of vitamin D is more common in low socioeconomic group is a very big myth. Actually, it's very wrong. What you should understand, the actually higher socioeconomic group kids who go to classrooms which are filled with AC and they never get exposed to sunlight or any sporting activity, they have more what do you say, vitamin D deficiency than the higher low social economic group actually. Next is dietary supplementation. You should understand one thing is that none of the diets that we actually take have vitamin D unless only milk and milk products, few of them are fortified with vitamin D. But that also doesn't give us entire vitamin D that we require for a day. So definitely you need to take supplementation or you need to get exposed to sunlight. So injections of what, there is a very big fashion that once you find out vitamin D deficiency is there, they want to give a very painful oil-based vitamin D injection. Actually, it's actually absolutely not required. In my entire practice of pediatric ortho, I never gave an injection of vitamin D to any baby. We just give oral supplementation, and oral supplementation are as very good as injectables. So injectables are specially given only when the baby has some other issue of gastrointestinal disorder where the absorption is low. Otherwise, most of the time we treat only with vitamin D supplementation, oral supplementation, the baby does really well. So next we'll be talking about deformities in kids. Many a time we see a deformity like this. This is a CTEV in a baby, newborn baby. And next we see something like a CVT. This is a calcaneal valgoid deformity in the baby. And next we see a genu recurvatum. That is the knee completely turn around and the foot touching the chest of the baby. And next we see some limb losses in the babies. So what a very major method that I have seen is that once they see a deformity at birth, many doctors also have seen telling them to wait for a few weeks till the baby grows a little. That doesn't make any sense. Most of these deformities have to be treated in the first week of life. So please don't wait for 4 weeks or few months and all, where the deformity becomes more and more rigid, and then it is more tighter for the baby to be corrected. So correction is even more harder in a bigger baby. So the younger the baby, the easier is the corrections. Next, operate and conserve everything. That is also wrong. See, few deformities actually don't require any treatment. We just tell the mother to do massages while feeding. And we don't operate most of the deformities at such a young age. We try doing only casting, serial castings and getting corrections. And also a baby which has been diagnosed at a very young age gets very good results with any kind of deformity rather than a baby which comes at a later age. Next, an adult orthopedician is enough. That is a very big myth. Understand that adult orthopedicians are not trained with pediatric cases. There is a complete different course and a complete different story of kids having deformities. So please find a pediatric orthopedician who is feasible and nearby for you to help your baby. Next, let's take multiple opinions. That also doesn't make sense. In any kind of deformity, any kind of issues, more than two opinions always lead to more confusion. And make sure that you are going to the exact consultant that you really want to meet, so that the person should be trained in it and practicing same kind of specialty since few years also is fine. So then they have very good knowledge about it and they'll guide you really well. So next is fastest and temporary solutions are the most commonly parents will be asking us, what is the fastest way of correcting it, and what is the immediate way of doing it. It doesn't happen that way. Most of the pediatric deformities actually will take their own time to get corrected, and you have to be very patient with them, and the follow-up also is very long. Next, let's go home and never return. Parents feel that they just go home and can't return back, don't need to return back, don't need to come back for consultation. That's not the way. You need to be in touch with the consultant that has treated you for a very long time. Next, too costly a treatment. Most of the parents that have had a beautiful baby now are ready to spend lakhs of rupees just for a 21st day function, a cradle ceremony and all this, but they feel the treatment costs of the baby's life. So this kind of deformity, once you correct, the baby is going to enjoy the benefits for the rest of its life. A normal average human life being 60, 70 years, I feel no treatment is costly for a baby actually. So next we'll be talking about knee deformities in kids. Many people see that this genu varum, genu valgum, that is having bow legs, or having genu valgum, that is knock knees, is kind of always abnormal. It's not like that. Till up to 18 months or around 2 years also, having bow legs is very normal in a baby. And next is 18 to 30 months, actually baby has a normal limbs. And then from there, from 3 to 4 years, the baby around till 7 years has genu valgum only, which slowly corrects into normalcy into adulthood. That means near the adolescence age group, 11, 12, like that, it gets corrected to normalcy like this. But if at all it is asymmetrical deformity and the baby has some kind of other genetic disorders or any metabolic disorders, then definitely it has to be looked into. So, and another great myth I result is that they tell that their grandparents also had the same deformity. That actually doesn't make any sense. Most of the babies, these kind of things are generally not genetic. So they will be having some kind of vitamin D deficiency or something like that, because of which the babies will be suffering, or most commonly they have physiological deformities only. But to find out what it is, the baby definitely requires evaluation. Many parents feel that why such a small baby, why are we doing blood tests, why are we doing scanograms, why are we doing some x-rays for them? Absolutely, we need to do some investigations to make sure that the baby doesn't have any problem. To find out that there is no problem, only we need to investigate. It's like that. Next, many people have seen suggesting braces, especially for knee deformities. There is no scientific evidence anywhere from anywhere in the world that braces have actually corrected a deformity. See, once a bony deformity sets in a pediatric age group, especially baby, it is never going to get corrected with just with a brace. Actually, you eventually have to operate it or wait for it to get corrected by itself over a period of time if you feel it's a physiological deformity. Whatever the situation, braces actually never help a baby. So please don't fall into this trap. Next, surgical interventions best done at adulthood. They feel that this kind of mechanical access problems, you better operate it when the baby becomes adult, like 17, 18 and all. That is not the way it is. Okay. The better thing is that when the deformity is there at the age of around 10 to 14 is the best time to operate this kind of deformities. We regularly do these procedures, and these are very small procedures, which are daycare procedures. Baby comes in the morning and goes in the evening, and within a year, the deformity gets correct completely. So that's the better way of going about it. Known as talking about fractures. This is a very lucrative kind of situation where we always go into. Every one of our relatives has a fracture. Each of us will have a fracture at some point of our life, actually. So there is something people talk like hairline fractures. There is no literature evidence anywhere in any orthopedics book comes something called as a hairline fracture. It is either an undisplaced unicortical break or any other deformity, but hairline is absolutely not there. Please don't talk like it was a hairline fracture, which is actually not written in any literature. Next thing is cannot heal. Many people feel a fracture cannot heal itself. It definitely needs some kind of surgery or some kind of treatment. No, actually, most of the fractures heal themselves. They actually don't require any treatment. The only thing is they don't heal anatomically. All the surgical interventions or immobilizations we do only to get it in aligned really well, so that your functional deformity doesn't happen in the patient. Next is massage needs a quack's touch. Going to a quack for a fractured bone is one of the worst things any patient can do. That's the kind of you yourself hurting yourself even more, because see, a fracture heals with a what do you say, a hematoma. Hematoma means it's a kind of blood pool that is formed around the fracture site. So what these guys do, they massage it so much and displace the entire blood pool. So the bone which has to be formed at the fracture site doesn't form there and forms somewhere else. So it's absolutely useless. So no massages, nothing at all. Just immobilize the fracture. If at all you just want conservative treatment, you can always ask your consultant to help with that. So next, hot packs. Many people have seen they apply hot packs to a acutely injured limb. Please don't do that. Always apply only ice packs. Hot packs are for muscle spasms. So whenever patient has muscle spasm, muscle catches or something like, hot packs help a lot, but cold packs are best for fractures and injuries, something like that. And next, operate every fracture is a very, very bad attitude. Actually, this I wanted to tell to my orthopedic friends also. Please, whenever you can conserve a fracture, always conserve. In pediatric orthopedics, we hardly ever operate a fracture because kids are like gods. They heal like gods. So up to age of 8, we actually never operate any pediatric fracture unless it's a very bad fracture like distal humerus or lateral condyle. There are some specific fractures which has to be operated. Otherwise, most of the times babies require, more than 90% of times we never operate a baby with a fracture. And conserve every fracture is also wrong. We cannot treat every fracture conservatively. You have to operate few fractures. There are specific fractures which require specific treatments. So you need to have that good knowledge about it. Next, prolonged immobilization. I have seen many people going immobilized, like they get operated for a distal femur or something like that, and they stay like that without moving their limb for 6 weeks, 8 weeks, 2 months, and all. That doesn't make any sense. See, most of the surgeries are done to mobilize the patient only. If you are not mobilizing the patient, there is no point operating him also, right? So most of the times we mobilize the limb within 4 weeks, 4 or 5 weeks, maximum 6 weeks. Beyond that, generally we always try making the patient as mobile as possible so that he doesn't get stiffness in the joints. Now, next is x-rays every week. This fashion I've seen with many consultants taking x-rays every week. That doesn't make any sense. See, when a fracture is healing, it takes at least 4 weeks for you to really show what, any change to see in the fracture. You need 4 weeks at least. Without 4 weeks, there's no point repeating an x-ray also. And especially pediatric fractures also, we take it 4 weeks only. So after that also, we need to repeat only after 3 to 4 weeks only. Every week, it's actually not going to change. There are some specific fractures which have a very bad tendency to displace after a few days. So that kind of fracture, specific fractures only, we take weekly x-rays. Otherwise, it's not required. So, and another thing is that leave the implant inside. Many consultants have seen telling the patient that the implant removal is not required. See, once the fracture has united and you have start walking and living your daily life, any implant is just a foreign body in your body. It's actually not, unless it's a replaced implant, like, they tell that they replace the ball of your head of the femur. That kind of things that you cannot take out. Baby patient will definitely walk on that. So otherwise, the plates, nails, K-wires, all these things have to be removed from the body. So this clears most of the fractures, myths of fractures. Next, another thing, diet and supplements. Calcium, our great calcium comes down here. I have seen tons and tons of calcium being taken by patients, kids, everyone, which is absolutely unnecessary. Most of the calcium is available in most of the day-to-day food supplements that you take. You improve that, that is enough. Just taking a calcium tablet won't change anything. This is a complete marketing strategy where calcium is just pumped into your body, which is absolutely unnecessary. Most of the times calcium is more important for pregnant ladies and postpartum ladies who are breastfeeding, or other people, or older people who are beyond 50-60 years, who have risk of what is it, pathological fractures. For them, calcium and in other forms also is better. More than that, vitamin D is more vital than calcium actually. So a patient with calcium deficiency usually doesn't come with a fracture. They usually come with other more severe disorders like what is like seizures or any other central nervous system issue only, rather than fractures of the bone. Next, another thing, many patients ask me that papu, that means this dal kind of thing you eat now, will you get infection in the wounds? That's absolute nonsense. See, papu is less, that is like a protein diet that is very useful, and actually giving that in during or post surgically or anything, it's very useful. Next is something called as patyam, very, very weird thing. They both think like you should not eat tikha, like, you cannot eat that kind of things which are little sour or something like that. So they are, many people ask me that. That doesn't make sense at all. See, it is not going to change the course of your fracture healing or anything. So it won't affect in any way. So don't think about that. Next, avoiding non-veg. Many people ask this, that should we avoid non-veg? No, that is good protein. You should always take good protein for you to get better. The most important thing in diet and supplements is that you need to take very good calcium-rich diet, and also take good vitamin D, and also other some bone healing drugs are there. So that we can talk about later, but most of the myths are these. So these are not you. This you should just skip out. Next, we'll be talking about physiotherapy. Once you have gone through all this, there is a branch completely called as physiotherapy, which has developed now. So many people feel I don't require it because I just had a sprain or a fracture or a surgery. It's not like that. Physiotherapy is kind of mandatory for any kind of orthopedic disorder, where we eventually put them into physiotherapy to get into better shape, as Prashant sir was talking, losing some weight and getting better into your health, and being a better performer. Another thing, start when painful to reduce pain. That doesn't make sense at all. When a patient has acute low back pain and all that, we never suggest physiotherapists to go around and teach them spine stretching exercise or strengthening exercise and all. When in a painful situation, always give rest. Always give rest, some cold or hot packs, and then take some medication. Wait for a while, and when the pain becomes little bearable, only we advise them to go for a physiotherapy session. Next is, let my physio decide when I need an ortho consultation. That's absolutely wrong. See, when you're not finding any difference and you are in very bad pain, chronic bad pain, you always need an orthopedic consultation and go to a specific, like you have a spine problem, go to a spine surgeon, go to our Srikantiga sir. If you're a baby, you come to me, I'll help you. Or if you have any other issue, neurological issue, go to your neurologist. So that will help you in that way. Please don't get stuck with one person and suffer for a very long time. So let's finish, and patients also feel, let's finish 1 hour session of physio and then rest for the next 23 hours. That doesn't make sense at all. See, you need at least 7 or 8 sessions of physio. That is at least for 10 to 15 minutes at your home. At least you have to continue physiotherapy. A home based physiotherapy regime also, we give 1 hour of session with the physio and rest at home. Actually, that is very, very important. You need to do 6 or 7 sessions at home also to keep your muscles in good shape and for yourself to get better. Next, I found this a very interesting ad. I am a great fan of Javed Akhtar actually. पर मैं चलता रहा और आज भी मैं कहीं रुकता नहीं. सहारों की जरूरत नहीं मुझे. मेरे हम सफर हैं डॉक्टर ऑर्थो, आयुर्वेदिक तेल और कैप्सूल. घुटना, कंधा, कमर, चाहे जैसा दर्द हो, ये मुझे देता है दर्द से पूरी आजादी, एक भरपूर जिंदगी. ये कोई टेम्पररी पेन किलर नहीं, आयुर्वेदिक औषधि. So he tells it's not a temporary pain relief, but it is a Ayurvedic aushadhi, and himself goes on a wheelchair. So that's the irony behind it. So he comes out of airport like this on a wheelchair. If he had all that, he would have been a Superman by now, right? Why should we need such big degrees to be operating cases? Yeah, so please don't go into that. So joint pains and arthritis, talking about it, happens in old age alone. That is a very big myth. No, now small babies also have joint arthritis because of various other diseases, and also young patients also in 40s also are having very bad joint issues. Next, magical oil that can heal, as we are talking about Javed Akhtar sir. That was a very sad ad, so please stay away from all this. Just an oil cannot treat you. Actually, it just gives you a placebo effect for a few days, that it produces heat and you get a little more inflammatory markers there, and the patient feels a little pain relief. That's it. It is not a permanent solution. Next, walking too much has led to joint arthritis and pains is wrong. See, actually the joints are made to be in mobility only. The lesser you walk, the more the bad they become actually. So being mobile and being exercising every day is very good. Next, surgery is the only option is also wrong. Up to the stage 3 of joint arthritis, usually orthopedic surgeons maintain only with conservative means, giving only medications and physiotherapy and nothing else, and lifestyle modifications also. So surgery is the last option. Next, there's a very big hype of intra-articular injections, which are told to be curing the entire. Especially, I've seen stem cell-based therapy just left and right being given. Please understand that giving stem cell therapy in India is completely illegal and it's not allowed, and it has no clinical evidence that no paper has still now proved that any intraarticular injection or anything really helps you, especially in severe osteoarthritis cases. So in early arthritis cases, hyaluronic acid injections are a little better, but usually most of the intraarticular injection, more than 90% are given unnecessarily. They're absolutely useless. And especially stem cell based any kind of therapy is actually not clinically proven. So please don't spend lakhs of your money just getting these useless injections which will not help you in any way. So that's about that. And many of us have this mentality that if it's on TV, if it's in papers, and if it's on YouTube, some guy is coming and has a 1 lakh subscribers and tells about it, then it should be true. Absolutely wrong. I'll show you some statistics for this. Okay, so types of advertising. This was a uh, us based person, what do you say, the study that was happening. So US based people feel around 46% feel that whatever comes on TV is very trustworthy. So whatever is advertised on TV is absolutely trustworthy. And also print media of 46% is also very much. And then what you can observe here is good thing in US people is that social media is on the base. Around only 1 out of 5 people feel that advertisements in social media are not very trustworthy. So next, this is another interesting thing. As you can see, this red and this pastel color one, this shows that mostly these are the mainstream media sources and people who are really associated with that field, which are whom the people feel are trustworthy. This is from 38 markets, that is all over the world. The biggest of 38 markets were taken into one study, and then this is only in India. So as you can see, these two things are very much approachable, and you can what do you say, you can go back home and research about it and you will find evidence about it. And these two things, the blue and the other color one, these two are absolutely uncertainty and information unchecked and hard to distinguish from news from rumors. So as you can see, India trusts this only most. 45% means almost every one person in two persons actually believes that what is information which is unchecked is actually right. And also social media, almost 1/3 of the population is stuck in social media, especially in WhatsApp university. So that's very sad for India. And next, trustworthy news that can be really checked, hardly 1/3 of Indians feel it is useful, like it is really, like it is going to affect and it's useful. So this is how the statistics are going about this. So please don't trust any social media posts or all this, what you know, TV media or print media. Please do your, what I would suggest you to take home from this kind of small talk is that is RRR, that is 4 R's actually. This here we have. So one is read about it and then research about it. Research about the topic that you really want to get done. And also review articles. Many things are there you need to. And also the final R is that reach out to the trusted source. They'll be a very good close friend of yours and he will have very good friends in doctors. That person can definitely give you a very good opinion about what is what in the problem that you are suffering. So that would be my talk. Thanks a lot. You can note down my number and WhatsApp me. And please, I want you also to put up the myths that you have heard, and I'll tell you if it is really a myth or a fact. You can post that in what do you say, our chat box, so that I can answer you or something like that. Thank you.
Thank you, Dr. Anand. Thank you so much for sharing the information. A lot of statistics also you have told, and your start of the presentation was very nice. With with that Tollywood movie extract. So it was quite. People were looking at you and see Dr. Prashant. We can see him smiling. So, so anyone that has any question, or we'll move to next presentation.
Yes, we'll move to next presentation. We'll try to keep questions at the end. I think presentation should be finished by the people. And if there is any question, we'll request you to put it into the chat box so that there is enough time for any one of us to think and respond. Who's the next presentation by?
Yes.
Yeah. So thank you so much, Dr. Anand. The next presentation is by Dr. Ashima Sharma. She's professor and head emergency medicine NIMS. And we are seeing Madam, teaching a lot of people about CPR, which is one of the must needed thing nowadays. Madam, it's the platform is yours now. Dr. Ashima Sharma, you're here, ma'am? Madam?
Okay. Should we have the second speaker ready?
I think we should, ma'am.
Hello.
Yeah,
Hello.
Hello, ma'am.
Yeah, sorry, I was not realizing that I was muted. So
yeah, please, ma'am. Please go
ahead. Okay. So thank you, as always, Dr. Ashish, to initiate such wonderful talk sessions between us uh, on World Health Day, and obviously all of us who have come out to talk about their speciality. And I was very impressed by Dr. Anand. Needless to say that he answered the common men's person's myths and facts very wonderfully. So I'll try to do the same with my session on something which is again very much in talk these days, and that is about uh, compression only life support, that is calls. So let us. I have not made any slides. 5 minutes, no need of putting in slides. Let's talk about why exactly this particular resuscitation protocol is the talk of the town. So we always, isn't it? We all doctors have already researched about BLS, that's what basic life support, ACLS, that is advanced cardiac life support, and we have been, few of us have done it in a proper way, or few of us have listened to it, read it in our books, and thought, okay, whenever the time comes, I'll do it anyhow. I am a surgeon, I don't need to resuscitate. I have anesthetists to come, or I have my friends, critical care friends, to help me whenever my patient goes down. So yes, this is one of the way few of us think about it. But then suddenly what happened? That we realized that fit people, those who were walking, those who were doing gym exercise, those who were playing badminton, those who were doing regular swimming, a regular exercise, those who were dancing in a wedding, and all those looking young, somewhere like 18 years, 20 years, 26 years, they are collapsing, sudden fall. And who were near to them were not us, unfortunately. Those who have read the books, have a basic understanding of basic life support, but were the people, laymen, who were the people around them. So the general public. So the public could not understand. First, to recognize it is so difficult for them. But and then to, after recognition, what to do? Obviously there will be panic. Obviously they'll start thinking what to do, whom to call, should I call the nearest doctor or whatsoever. And this we saw it in all, in the WhatsApp, as that there was, recognition was a problem. People were not able to recognize for good amount of time, and that was so seriously bad. Let us talk about the fact that how would what else should be done. So who's among us, there are good Samaritans, who are teaching general public, young students, whosoever around them, this life CPR. So what should we teach them? That is what I'll talk to you today. And that is what has to be taught, is compression only life support. Now, what does that mean? It means whatever I've said. We are, this is among us, that our teaching is like this, that I can feel a carotid pulse. But if I ask my daughter to feel a carotid pulse, not possible. If I ask my worker at home, or not possible. Healthcare workers, be it doctors, nurses, and even our people who work along with us, they understand what are we saying when we are talking about carotids, isn't it? So the first step in a calls which should be taught, is to check for responsiveness. So anyone who collapses in front of your eyes, that is a witnessed arrest. very important point is to make them understand that reversibility is or depends upon witnessing the event. So in a witnessed arrest, someone collapses in front of you, just check out for his consciousness by tapping on his shoulders and talking out loud. You know, hello, how are you? That is how what is exactly what we have been trained in BLS also. Yes, scene safety comes first, but then uh, most of the time the scenes are safe up till until it is not an electrocution where we should not approach till the power supply is cut off or the what we are witnessing is in a place where a busy road is there. Apart from that, every scene, other scenes are probably safe till uh, if not in any atypical situations. Let us say after checking for responsiveness, what else? So if the person responds with something like some voice, that means he is not arrested. That means that he only needs your help to make him right lateral position. Call for ambulance, yes, because he has collapsed. He might be having stroke. He might be having some hypoglycemia. He might be having some other reasons. He might have had a seizure activity, uh, and that is where he should be taken to the hospital. But yes, he definitely does not need compressions. By compressions, I mean chest compressions. But if he does not respond, no need to check for pulse because layman, it is not us. It is not our healthcare workers. It is the lay public. There is no need to check for pulse. There is no need to look for breathing. Go ahead and identify the lower part of the sternum and just put two fingers above the xiphy sternum and then start compressing. Now, I'll tell you when I tell all this in my talks at other places, xiphy sternum comes so easy, isn't it? I'm telling you, and you are able to understand what I'm trying to say. But will it come the same to a common man? Not at all. So what they say, what they do is to tell them middle of the chest, lower part, not in the center of the chest, because in the center of the chest, that is the part which they will be doing it for right ventricle, and that will cause more of not effective compression. So there is a little science behind it, but beyond the science, telling them to do it on the lower part of the chest, in the center of the chest, and making sure they are locking their elbows. So that is something which has to be told. So one security guard I was teaching, and he was saying, he was pointing towards another one and saying, "Iska biceps zyada acha hai, madam. Ye acha compressions karega." So there is no need of having biceps because it is the body fulcrum which is doing the compressions for you. It is not that someone who has good biceps would be doing better compressions. Okay, so I have just told you the biggest difference between basic life support and calls. In basic life support, you definitely take 10 seconds to identify breathing, identifying consciousness and all, carotid pulse, I mean. But in this, you just go ahead and start compressions. If you are alone, you have to put your phone on speaker and dial for 108 while you are doing all this and inform the 108 people about the scenario. If you have another person along with you, you are the patient, the victim of cardiac arrest is lucky to have two gentlemen passing by and seeing, then that other person can do the call for 108. Chest compressions only are the main source of resuscitation for compression only life support. It, okay, so what I say is there is, we all know there is one law, IPC 302, isn't it? So 302 is what if the patient dies in or a person dies under mysterious circumstances, it is 302, isn't it? So, if it is a healthcare worker, it can be split. 30 can go on one side, that is 30. 2 can go on the other side, that is 2. Becomes 30 compressions to 2 breaths you have to give. But that all can be done if there is a paramedic, a healthcare worker, a doctor, or a nurse at the scene. But who is there on the scene is their common general public. They will do only compressions. Let them not waste time in trying to give breaths, because we know that most of the adult people who are collapsing secondary to cardiac issues. Very rarely adults are collapsing with respiratory issues, where yes, I would also agree that giving breath would help. So compressions, how to do compressions? Well, I can only say that you have to go deep and fast. So push hard, push fast. Remember, on an online medium, we can teach someone how to ride a bicycle, but till the person doesn't ride it on the road and falls, not possible for him to learn the nuances. So I'll just say push hard and push fast. That is what you have to tell them. Let them not count it. It is not possible. We have this nature of counting because we are tuned to it. General public, just let them keep on pushing. Feeling tired, get out of this, let the next person start doing it. In the meantime, in that all that panic, ambulance will surely arrive. So that is what I wanted today's uh, opportunity to discuss with my colleagues out here, to tell them that when they are teaching to the general public, please, basic life support is not supposed to be taught to general public. It is compressions only life support which has to be taught to general public. I hope I have conveyed my message to you all. Thank you so much.
Thank you so much, madam, for the information you have given us. And very rightly said, till we don't know, we really don't know. We have to do it to learn it. Thank you so much. We look forward for more sessions to hear from you. And we will take the question and answers in the last. Now, I would like to invite our next speaker, Dr. Shrikant Iga. You there, sir, in the room?
Yeah, I'm here.
Oh,
I'm audible?
Yes, sir, you're audible. So, Dr. Shrikant Iga is a spine surgeon with 11 years of expertise in treating all spine problems and 14 years in orthopedics. And he's practicing at Spine Sure Clinic, Kondapur. So, he's a very recent member in our group, and we are meeting him for the first time. I'm meeting him for the first time. So, the platform is yours, sir.
Yeah, I'm sharing the screen.
Yes.
Just enable it.
Yes, you can share your screen now.
Okay. Okay. There is some security concern which is shown. Just a minute.
Is it allowing you to do that?
Yeah, just a minute, ma'am.
Okay, no problem.
Just
Yeah,
yeah,
yes,
just a minute. I'll do it from the phone. I think my laptop is giving an issue. Just a minute. Yeah.
Please go ahead.
Just I'm sharing this.
You're still facing the issue?
Yeah, only host can share, it seems.
No, I have given you the right. You've joined with the same name?
No, this is different, ma'am.
Yeah,
Can
okay.
you see now?
Yes, yeah, I've given you the right again. Please check.
Yeah.
Can you?
Are you able to see the screen?
Not yet. We can see you, but we cannot see your screen.
Yeah, are you able to see now?
Yes, we can see the screen.
Yeah, just.
Yes.
Yes, ma'am. So, hello all. Sorry for making it delay. So today my presentation is about sciatica. So which is one of the most common problems in spine. Uh, so basically the sciatica is a term which is used when there is a compression on the sciatic nerve and there are symptoms causing because of it. So this is the sciatic nerve which originates from the lower 5 nerves of the lumbar spine. So whenever there is any pressure or this nerve, there are the symptoms which are seen. So normally there is a reserved space for this nerve. For the spinal cord, there is some reserved space. But usually when this sciatica happens, when there is a disc prolapse and the disc is pressing on the nerve. So you can see there is a reserved space for the spinal cord, and the one which is marked in the red, it is a reserved space for the nerve. The nerve is exiting from there. But what happens in sciatica is the disc comes out like this and it creates a pressure, mechanical pressure over the nerve, and it releases some chemicals. So because of these two reasons, there is the irritation of the nerve and there is a sciatica pain. So what are the causes of these are basically the genetic causes. Obesity is one of the main reason causing sciatica. Lifting heavy weights, the people who prefer traveling long distances, who are very sedentary, who have a very sedentary lifestyle. Smokers and alcoholics do tend to have a more frequency of disc prolapse and sciatica. So the main symptoms are back pain in to start with, and in younger patients will usually have only gluteal pain, not the typical radiating pain, but the gluteal pain. Older people will have a more of a radiating pain down the leg, which aggravates on sitting, standing, and it doesn't allow them to walk. They will have symptoms like numbness, paresthesias, and very rarely, few patients may develop weakness of the muscles, weakness of the plantar flexion or a dorsiflexion of the foot. And in very few cases, I mean, in 1 in 200, 1 in 300 cases, patients may have bladder and bowel symptoms. So this is the extreme stage of sciatica. So coming to the treatment model is, as Anand said, that a lot of tantrics in India. So this spectrum, the spectrum of backache with sciatica belongs to a lot of specialists, like you can say the quacks, Ayurvedic doctors, homeopathic doctors, Unani doctors, general medicine, orthopedicians, neurosurgeons, spine surgeons. A lot of people treat them, but a lot of them don't know how to treat it, which way to go, and when is the surgery needed, and when it can be managed conservatively. So 80 to 85, in fact, 90% of these cases can be managed conservatively. As I said, when the disc comes out, there is a mechanical pressure and the chemical release. These chemicals get neutralized by 6 weeks to 2 months of time. And the mechanical pressure, which is created by the disc, the discs come out. That is why the mechanical pressure is created. This disc usually gets absorbed in 6 months to 9 months of time. So majority of people get okay with it, with conservative management, with medicines and good physiotherapy. Few of them who have problems with this, who are not responding to the conservative management, they can undergo simple pain blocks. You can see there is a nerve compression here where the disc has come out and pressing on the nerve. So what we do in this is we pass an injection needle over that foramen near the disc, and this is the picture showing the disc prolapse. The disc has come out and pressing over the nerve. So what we do is we pass a needle, then we pass a dye just to confirm the root of the nerve. Here it is clearly seen there is a passage of the nerve with the dye, and then we inject the medicine by which the chemicals which are released are neutralized and the patient is symptomatically relieved. And very rarely the patient in the pain blocks, the patient usually responds 80% of times, and the relief is there from 3 to 6 months. In 50% of patients, the relief lasts for the entire life and they doesn't need any kind of procedure. Few patients who doesn't relieve even with blocks or are having severe weakness or any bladder and bowel issues, in those patients we advise endoscopic surgery. It's simple, very small surgery wherein we take out this much amount of disc, huge amount of disc. You can see the syringe besides, with a very small nick, 8 mm of incision. If not, then we can go and do a microscopic discectomy, where we take out this much amount of disc with an inch of incision. Otherwise, we can proceed with the typical laminectomy discectomy. This is the normal way we can do this. Yeah, thank you. Hello?
So we can hear you. I'll just check. Yeah,
Hello?
please go on. Please go ahead. Please go ahead.
Yeah. So are you able to see the screen, ma'am?
Yes, we can.
Yeah. So that is it, ma'am. The treatment, what I wanted to highlight here is majority of the sciatica patients can be treated conservatively if they are managed in a correct way and if they are directed in a correct way. Otherwise, many of them land up in a surgery which are very much unindicated. Patients who need surgery they fall in a very small spectrum, which can be managed very well with today's modalities like endoscopic discectomy or microdiscectomy.
Thank you. Thank you so much. Thank you so much for the information you have shared. Okay. If you don't mind, can we stop sharing the screen?
Yes, ma'am.
So we'll take up the questions in the end, and that was a quite informative session. Yeah. So our next speaker for today is Dr. Sharmila. She's MD Pediatrics from Osmania Medical College. She has 20+ experience in the field of neonates and pediatrics, both in intensive care, OPD and inpatient care, ranked in the top 3 pediatricians in South India by India Today, and head of the Department of Pediatrics and Professor DNB Pediatrics, Jubilee Hills Apollo, Honorary Associate MD Program from Australia, Tutor University Fellowship Program in Pediatrics and Pharma D Program, awarded multiple healthcare awards and has publications nationally and internationally, passionate about preventive pediatric care, and shares parenting tips on YouTube and television talks. We are very honored to have you here with us, madam. The platform is yours. Ma'am, yeah.
So thank you, Garima, for that generous introduction. I don't think I'll be talking as much as my introduction also. So yeah, coming straight to the topic, because I think it better be short and crisp so that we address to the most often asked question to me. I would say for the past 6 months is, why is my child falling sick often? It's every once in 2 weeks, sometimes once in 10 days. Is the pediatrician missing something? They would come to me. At least 30% of my OPD is that they would visit a nearby pediatrician and then come to me. So they'll keep asking me, why is it? Did the pediatrician, are we doing the right thing? Is the pediatrician the right person, right advice being given? Or is it something to blame on the school authorities or the child? So there are so many apprehensions. So the first thing I would like to tell every parent out there who's listening to this talk, in fact, some of the doctors also get their children and ask the very same thing. So you're not alone. You're one among those millions of children, not just across India, but all over the world, who have been falling sick very often after COVID opening up. And the answer, obviously, I mean, is too obvious a thing. Like you've been shielded for 2 to 3 years, and then you suddenly got exposed. You're almost like a neonate, and someone who's put, if you're taken a neonate to a school right away within the first month of birth, that is what happens. So you're non-immune. Your body immune system just forgot about most of the viruses circulating. And thanks to COVID getting so much attention, even the viruses are feeling jealous of COVID. And now, I'm not kidding when I say that the way each virus is causing disease, its own pattern, its own behavior has changed for the past 6 months. We never would encounter children with respiratory syncytial virus, pneumonia in older children. In fact, I hear reports from adults also across the world suffering from RSV pneumonia. This, mind you, in immunocompetent individuals, not in the immunocompromised alone. So similarly, many other viruses, adenovirus would have been any other virus with a simple small red eye, sometimes not even a red eye, a little fever, cold, cough, and they wouldn't even see a doctor for a 5-year-old or a 10-year-old. And these days, adenoviral pneumonias are sometimes, probably I would still say majority do not need hospitalization. Majority, I mean 99.96, 97%. The 2 to 3%, which would be probably 0.2 to 0.3% earlier, are needing hospitalization for various reasons. The commonest being dehydration, very high temperatures. The last 20 years, I would say anyone with 103 fever is high fever. Now I'm seeing 104 and 105, not so uncommonly. Probably once a week, I hear children being brought to me saying they have temperatures recorded like 104.5, 104.8. And like even I am surprised. I've never seen this happen prior to this 1 or 2 years so frequently. It would be one-off child with that kind of temperatures, and most of the times they would need admission. But again, I would like to tell you that the other change in pattern that as a doctor I've seen is that inflammatory syndromes have increased. Previously, viral fevers would be 3 days, 5 days, 7 to 9 days maximal. We would start investigating a child with an older child, somewhere between 6 to 15-year-old child. We would investigate such a child only after, say, 4 days of fever if there are no other alarming signs. But now, children commonly are having temperatures up to 7 days. If they're not too high temperatures, if they're not dehydrated, if they're not vomiting copiously, if the abdominal pain is not too bad, we are starting to investigate at 5 to 7 days. And then what I talk to as inflammatory syndromes, these are quite common after the virus has finished its job of causing fever. The body's immune system itself is attacking itself. What I would say, a parallel can be drawn to a cytokine storm in COVID or Kawasaki disease, incomplete inflammatory syndromes, then systemic inflammatory responses. These have become rampant. And for viruses that would previously not cause so much of an inflammatory response. In fact, we have now one child who was in a very morbid state when it was referred to us, a systemic inflammatory response. Something like pleural effusions, fluid into the lungs, fluid into the abdomen, and all this caused by influenza B. Okay, this is all medical knowledge, I think, which seems irrelevant to parents. To parents, again, I would like to tell you, you don't have to panic if your child is falling sick frequently if the duration of illness is anything less than 5 days. Number one, again, the duration changes for each age group. I wouldn't like to get into too many details for neonates, post-neonates, toddlers, and all those. A rule of thumb is anyone getting a fever for less than 5 days, if they're not getting dehydrated. How do you know that at home? If they're passing urine at least once in 6 to 8 hours. If they're not vomiting copiously, if they've not thrown a seizure, if they're not complaining of too much of headache or tummy pain, you are safe. If the fevers are continuing for more than 5 days, you definitely have to get investigated. If the child is vomiting copiously, throws a seizure, complains too much of headache, body pains, tummy pain, loose motions, ear pain, or breathing difficulty. These days, I've seen a lot of increase in adenoidal infection. These are something akin to tonsils in the throat. So they come with noisy breathing and nasal block, which extends for weeks together. If any of these signs are there, you should go and see a doctor. Again, 99% of these can be treated in the outpatient department and nothing to worry about. So this is what it is. Yes, the kind of medication we use is changing these days. Probably we are needing to use antibiotics a little more than prior to COVID. That is number one. For children presenting with severe ear pain, and most of these viruses have made children susceptible to overlying bacterial infections, particularly in the younger age group. These are the children who will need antibiotics. And then there might be children with severe hand, foot, and mouth, or adenovirus, or oral ulcers, who cannot take orally and who might need IV fluids. Even that is not frightening at all. 1 or 2 days in hospital and they get discharged. So overall, I would say with all those viruses around, whether it's respiratory syncytial, human metapneumo, influenza, the swine flu is H1N1, which is influenza A, the H3N2, which has caused a lot of fevers, colds, coughs, and a couple of pneumonias this year, and influenza B, which is also causing problems. All these influenza illnesses can be prevented by a single flu shot every year. The recommendation now is to take a flu shot for all children yearly till 5 years. This is the IAP recommendation, and I personally recommend all children to take a flu shot this year and the next year too. Influenza is causing more number of fevers, more hospitalizations worldwide, not just in India. So just take a flu shot. Even if you were to develop flu, it would be less intense and would not need anything beyond simple fever medication, cold cough medication. So overall, I would like to reassure all the parents out there, there is nothing to panic at all. Your child is fine immunologically, even if they were to fall sick every once in 2 to 3 weeks. And right now, the fevers have abated a little bit, but don't be afraid if your children are falling sick frequently, but then take one consult, at least an online or a physical consult, whenever they fall sick. Because sometimes you might not be able to know what are the warning signs when you have to visit your doctor physically. So I will add one small sentence to this. there is what is called fever phobia, which is described by one of the famous pediatricians, Barton Schmidt. And it is interesting to know that most parents are afraid their children's brains might get damaged with high fever. Yes, I wouldn't want parents to sit over a fever and feel good about it or feel neglect a child with fever. But then I would like to reassure that less than 0.5% of fevers can cause whatever you think, either severe dehydration or a fit or any other neurological illness. So don't be afraid of fevers. Use fever medication. Give lots of water. Sponge your child, sparing the chest, and you'll be fine. Visit a doctor. Take a consult either online or offline. Thank you for patiently hearing.
Thank you, ma'am. Thank you for that information. Yeah, that's really very true that kids are really getting sick very frequently and parents are really worried about it. So you have given a lot of information. And anyone, do you have questions to ma'am?
There is one small thing that I forgot to tell, which I would want to talk on all the platforms. Many of the times, parents do not know what fever means. Fever means armpit temperature more than 99. Anything less than 99 degree Fahrenheit in the armpit is not fever at all. There is nothing called low fever.
Okay.
Okay. Fever means temperature above 99 in the armpit, 100 or above in the oral cavity. For children older than 5 years, it's better to record in the oral cavity, less than 5 years in the armpit.
Okay. Thank you for that information, ma'am. So we have one question for Dr. Shrikant and one for Dr. Anand. And first, we'll have question with Dr. Sharmila. So Mr. Rajiv Verma says that your information was very crisp and clear. Thank you, sir. Srinivas, Dr. Srinivas has raised a hand. Yes, sir, you can go ahead.
No, I think it's an excellent information, Dr. Sharmila.
Thank you.
Quite relatable even to the internal medicine consultants about these fevers these days. One question, it may sound very silly. The last point that you mentioned, sponging sparing the chest. Is there any scientific reason for sponging sparing the chest?
Is they'll start shivering more, and children are very, very reluctant when you try to sponge them on the chest and the face. But then forehead, I always say you can put a putty. And sometimes parents inadvertently use very cold or ice cold water, and that might stimulate a parasympathetic sudden vasovagal kind of response in a child when you do that cold sponging on the chest. So I think it is dangerous for someone to do that at home. How much ever I tell them, you have to use only normal water to sponge a child, normal tap water. It should not be cold. Cold water actually induces shivering and increases the temperature. The child is also reluctant, fighting all the time. You should use normal temperature water. And sometimes in very cold weathers, I would say that if the tap water is very cold, you probably have to make it normal temperature before you sponge a child. Other than that, there's no scientific reason.
Thank you. No, it's
giving a blow or throwing anything super cold at the chest can sometimes cause a vagal.
Thank you for that information, ma'am. Thank you, sir. Thank you, sir, for asking that question. Thank you, ma'am. Even I have come across a pediatrician who has mentioned that earlier, that we should not do that. So, ma'am, I have a doubt here. We get those strips, fever strips nowadays we are getting in market for the kids. Is it recommended?
No. See, which one are you talking about? The fever.
There's some strips which is I'm not able to recollect the name.
Alcohol strips.
Something which you put it like fever strips, which it's a they put it on the kids, and it is like jelly based thing.
I have no idea about that, but measurement of temperature, I've been insisting on this. All kinds of fancy thermometers into the ear, I mean, just that infrared, and then very strange places they may record temperature, and then they come and tell me that the child is having a fever. So there are only two places I insist: less than 5 years armpit, more than 5 years oral temperatures. That's all. The ideal, obviously, medically is only rectal, which is not accepted culturally. So the next best are these.
What's your point, ma'am?
So the other recording temperature recordings are not reliable at all. It depends on the blood supply to the skin, blood supply to the tympanic membrane, then all these mishaps are there. So
okay. Do we have any more question to Dr. Sharmila? So Dr. Anand, are you there in the room? Okay. I think he's away from the desk. Okay. So Dr. Ashish, you want to add something? It was really a
I'm
nice...
very much here and love the discussion also. Thanks a lot, Sharmila. It's always nice to have the right kind of snippet from you.
Yeah.
Am I audible?
Yes, sir.
Yeah, you are.
Are we having Shruti's presentation? Is she around?
No, sir.
No. Okay. I would want to add a couple of just minute points. Yes, it's a great to hear Sharmila and Anand and Shrikant and others. World Health Day should be about preventive and proactive measures. Only reasons mortality happen primarily is because of reaching hospital late. Two big killer words of Telugu land is avasarama, nenu anukunna. If only these two words, the hospitals, the patients do not use it, ICU will close. 99% of ICUs will close, and we will be able to relieve Satish sir more for the administrative work rather than involve into the critical care work. He knows it well. We all know it well. Now, what all is needed being preventive and proactive at this time is acronym HEALTH, if somebody wants to write it down. HbA1c regularly, at least once in a year, because you're living in a diabetic capital of the world. HbA1c has to be tested. ESR regularly once in a year, because we are the ones who kill tuberculosis patients maximally in the world. Everyone sitting here has a tuberculosis. It's hidden, it's latent format, but people do not understand it. When I say chronic cough, this is a COVID positive. I said the hidden TB is coming out at this time. H is HbA1c, E is ESR, and S is apolipoprotein now, which is a small little a lipoprotein. All the cardiologists know it. You know, so you need to have a lipid profiles done, and apolipoprotein is something which is very much important to be focused upon it. Regular usage of statins. L is LFT. You consume alcohol, make sure you check your liver at least once in 6 months minimum. You are obese person, your BMI is more than 25, check for your LFT once in a year for sure. T is TSH. I believe anemia, diabetes, and thyroid are the most common diseases which gets overlooked. People do not like to treat TSH between 5 to 15. When I have had tons and tons of my patients who have reached even ICU also, just because we didn't reach a TSH of 7 and 8. Gone are those days when you used to treat only TSH more than 15. HEALTH, and final H is have your immunizations. I'm not going to talk about COVID, but yes, flu shots, pneumococcal vaccine, DTaP, MMR, hepatitis B, all of us should take it. We should promote it to everybody. And if you have not taken flu shot this year, please take it. With these few words, the picture which I had shown in my book, whichever, that was the time I'm having with my child. So sorry for that. But really, really enjoyed the lovely presentation. I'm very delighted to have Rajiv Verma with us. He's from Tata, who promotes the solar energy. Solar is very much needed even for our body. We know it. We had a discussion on vitamin D. We're very delighted to have Dr. Anita and she's popularly known as Shirin's mom with us. We're very happy that, you know, Paul and Anpurna ma'am and the birthday baby, Dr. Srinivas, is here. His party is due for all of us. I'm very much sure we can pull him for the next time. And next time we're not inviting Sharmila for any presentation till the time she gives us a party for her name being featured in India Today. It's really, really nice to have such a lovely crowd with us talking it out. Thank you. Take care. God bless. Any comments from anybody else, or we'll call it off because already short the time.
Ashish, your what is acronyms are marvelous always, and we try to learn a lot by the style of your presentation. Very crisp and to the point and interesting at the same time. Thank you for providing this platform and getting all of us together, Ashish, Garima, and all of you.
Thank you. Thank you. We'll close for the day and I'll share the recording in a while. Thank you so much.
Thank you.
Thank you,
Thanks
sir.
a lot. Thank you.
Thank you, Rajiv Verma and everyone. Thank you.